babies get a little bit tricky with the eye exam. So what does it look like? Well, first, about an hour before I even come in, the nurses have put in dilating drops into your baby's eyes. These are super safe. They use a very mild dilation drop, but it's going to make the pupils large for about 4 to 8 hours. That's put in about an hour before I come in because it takes about an hour for those drops to take effect. So you'll see the nurses maybe put those eye drops in, and they typically will do 3 sets about 5 minutes apart, depending. Once the baby's eyes are dilated, that's when I come in with my nurse coordinator. And oftentimes, to be honest, I tell parents, you can just step outside. If it was my baby, I definitely would not want to see the exam. Not that I'm doing anything damaging, but the baby is going to cry. The light is bright. It's just one more thing that can feel traumatizing. And the exam really takes about 5 to 7 minutes. And I tell you right away exactly what has happened. So once I come into the NICU room, depending on the type of isolate that your baby's in, my nurse is going to wrap the baby, swaddle them real good so that they can't move. And then I actually will put in a numbing drop into the eye. So that's going to help with any pain. And then I put in a wire speculum. Now, this wire speculum helps hold the eyelid open. And we have to do that because if you've gone in for the eye doctor's appointment, you can hold your own eyes open. Obviously, a baby can't, especially with a really bright light. Then I put my headset on, which is an indirect ophthalmoscope. It's got a bunch of different prisms, and along with the magnifying glass, it allows me to get a really magnified view of the retina. And this is why we had to put the dilating drops in. The dilating drops open up the pupil. So think about it like opening up a window really big to see a better view instead of just looking through a little crack. That's why we need to put the drops in. You can't really see well if the baby's eyes aren't dilated. And I really have to see into the entirety of the retina. So I have to see the periphery of the retina. So again, if you've ever had your eyes dilated and you go into your eye doctor's office, likely they would say, okay, look up and right, look to the right, look down and left. We're trying to get to the periphery of the retina, see everything all around. Obviously, with the baby, you can't tell them where to look. So this is the part that I think a lot of parents have trouble with, and I would too. I'm a mom of 3. I would not want to see this on my own child. We will use a little instrument to move the eye around. Sometimes it's just a Q-tip, like a very skinny Q-tip called a Calgi swab. Sometimes it's a little metal instrument that looks like a spoon called a scleral depressor. And that's how we can move the eyeball around so I can see into the periphery of the retina. Because what I'm trying to judge is where are the retinal blood vessels? Because like I said, at 26 or 28 weeks, the baby's retinal blood vessels have not grown all the way into the periphery. So I need to figure out at what zone are those blood vessels, and then I keep monitoring until we see that vascularization, those blood vessels fully grown out to the very edge of the periphery the way we would for a 40-week-old. Now, unfortunately, because the baby's premature, that means that it's not going to happen right at 40 weeks necessarily, but usually that's where we see full maturity or mature vascularization. So there's different zones. It starts with the centermost aspect of the retina because that's where the retinal blood vessels start. They start from the center and then they grow out and then they grow to zone 1, zone 2, and then zone 3. Zone 3 is the last zone right before maturity. So we're looking at the zone, the location of the blood vessels, and then I'm also looking if I see any retinopathy of prematurity, if I see any abnormal blood vessels. And there's different stagings for that. So there's stage 1 all the way up to stage 5. So stage 1 is when I see a little line. The blood vessels have just kind of stopped growing, but there's nothing super abnormal yet. This is pretty mild retinopathy of prematurity. It is ROP, but it's mild. It's nothing to be worried about. Stage 2 is when there's a little bit of a ridge. Okay, we're getting, the blood vessels have grown. There's a little bit of abnormality. It's something that we're going to continue to watch. It's not no ROP. It's not stage 1, so it's a little bit more concerning, but typically not anything we have to treat. Now, stage 3 is a little bit more concerning. That's when we start to see some bleeding. These blood vessels have started to break and caused blood in the retina. And that's when we start to you might notice, all right, now the eye doctors are coming a little bit more frequently, especially depending on what zone it is. Stage 4 is a partial retinal detachment. Hopefully, your baby is never going to get to that stage because we usually intervene at stage 3 level. And stage 5 is a total retinal detachment. And if it comes to that, this is very hard to treat. This is what can lead to blindness. And this is why we do these eye exams so frequently, so we can continue to monitor, because it can go from stage 0, which is no retinopathy of prematurity, just immature blood vessels, to stage 3 or stage 4 within a month. So a lot of times we are monitoring very frequently, especially if your baby's really preemie, if your baby had a lot of oxygen, or if they were really small. When do we treat? There were a couple studies, one called ET-ROP, one called cryo-ROP. I'm not going to bore you with the details, but these studies really showed us as ophthalmologists when is the best time to treat. When will this ROP, this retinopathy of prematurity, just go away on its own? Because sometimes it absolutely can. So they kind of looked at all of these babies, and they looked then at which stages progressed to that terrible blindness from retinal detachments and which ones didn't. Because we only want to treat the babies that really need it. Treatment's not completely benign. There are risks and side effects associated with it. And if it's going to go away on its own, then we're not going to treat. So as I mentioned, stage 1 ROP, we generally do not treat that. Usually that's just going to get just resolve on its own. Even we might just watch it every 2 weeks. That's typically the standard screening, is every 2 weeks we'll come in until we see mature vascularization. Most of the time, the blood vessels become mature. I say, see you later in my office in 6 months, and I really never have to worry the parents about any of these discussions. Stage 2 as well is going to be something that typically resolves, and that's what they found in these studies. Now, what they found is if there's really severe disease in that zone 1, that central area, that has a higher percentage of progressing towards a retinal detachment. So those are the things that we need to treat. Those are the cases that we have to act to prevent blindness. This is called type 1 ROP. We used to call it plus disease. And sometimes even in zone 2, if it is a very advanced stage 3, and there's many different types of criteria for that, but even in zone 2, we might need to treat. So it really does depend upon the zone and the stage and just how abnormal the blood vessels are, if the ophthalmologist is going to recommend treatment. So what they found in these studies is if these babies with really advanced disease in zone 1 or in zone 2, kind of moderate disease as well, if they're not treated, then 45% of them end up losing vision. But early treatment can cut that risk in half. So that's really huge. And that's where we make these decisions about recommending treatment. For more tips on eye health, parenting, and staying focused in a busy world, follow me on Instagram at Dr. Rupa Wong, or head to drrupawong.com. Until next time, keep your vision clear, your priorities focused, and your family thriving.